Right. So, good morning to all of you. Once again, uh, we are continuing with the classes pertaining to the gastroenterology, and now coming to the specific organs of the GI tract system. Uh, that is the first one to discuss is the uh, esophagus. Esophagus, as I told you in my first lecture, that it is only a conduit for food from oral cavity to the stomach, and it has got no its secretion. How the food propulsion takes place in the esophagus. See, UES, that is the upper esophageal sphincter, it relaxes after entering the food. Right? Peristaltic waves, they do take place. They help in propulsion of the food from the pharynx down to the esophagus. These are all mediated by the lower cranial nerves. Remember, if you can remember my first lecture, I told you that all of this peristaltic waves and this is being dominated, or you can say controlled by the neurotransmission by the brain as well as by the hormones. Right? Since from the esophagus no hormone is being secreted, right? It is only a conduit of the food from the mouth to the stomach, and all the peristaltic waves which are happening in the esophagus, they are mediated by the lower cranial nerves, right? In addition to that, secondary peristaltic waves occurs, which are induced by the local distension of the esophagus. Once the food goes into the esophagus, then there occurs the local distension of the esophagus, and as a result of this, the afferent goes to the brain. From there, the afferent comes to the esophagus, and as a result of this mediation of the neurotransmission, there occurs the formation of the secondary peristaltic wave, which propels the food toward the stomach. And as a result, LEX, that is the lower esophageal sphincter, relaxes to allow food into the stomach. Right. So whenever you are taking the food, it is the upper esophageal sphincter, right, which relaxes after entry of food. There occurs the primary peristaltic wave, which help in propulsion of the food from pharynx down to the esophagus. There occur the secondary peristaltic waves, which are induced by the local distension of the esophagus, and it propels the food toward the stomach, and the lower esophageal sphincter relaxes to allow the food into the stomach. Right. Esophageal disease symptoms. What are the various esophageal disease symptoms? The first and foremost is the and and I and I can say that approximately 95% of the patients who are having the esophageal related diseases, they complain of the dysphagia or the odynophagia. Right? Dysphagia, difficulty in swallowing, and the odynophagia is the painful swallowing. Right? Patient may complain of the chest pain or the heartburn, since esophagus is there in the thoracic cavity. Right? It is a long pipe, you can say, of around 35 to 40 centimeter, and it transfers the whole thoracic cavity, and if anything is related to it, then it can cause the chest pain or what we call the heartburn. Right. And the acid regurgitation, that is what we call that is the gastroesophageal reflux disease. I will tell you one by one. Dysphagia, difficulty in swallowing. You all must be knowing by now what is dysphagia. It may be associated with painful swallowing. That is what we call the odynophagia. Okay, right. The another variant includes the globus. That is a sensation of a lump or foreign body in the throat. Right. It is usually in the hysterical persons. It is a functional disorders. It doesn't carry any significance, and we see a lot of patients who complained of that there is some foreign body sensations, some foreign body, you can say, foreign body sensations are there in the throat, and there is some kind of lumpish feeling, right, is there in the throat, and in the upper chest. And if we do the endoscopy, if and we don't find anything. We don't find anything, and most of the time these people are then labeled as that the patient might be having some globus. That is it is a false sensation of, right, lump or the foreign body in the throat, and it is usually seen in the hysterical persons. So it is a functional disorder per se, but yes, dysphagia or odynophagia, they are the organic disease and should be dealt with seriously. As far as the etiology of the dysphagia is concerned, right, there is a huge list. I must tell you, either it can there can be two type of the dysphagia. Either it is a mechanical nerve of esophagus, right? There is some mechanical obstruction, right, like foreign body, fish bone, swallowed piece of food. We have retrieved all of these things. We have retrieved the fish bones. We have retrieved the this. foreign body. We have received the this cells, battery cells from the esophagus. We have received the coins and all these things. So any foreign body infection which cause the mechanical narrowing of the esophagus, then it is likely to cause the dysphagia. Congenital atresia of esophagus, just remember this term. Esophageal atresia is an anomaly, and you will see in pediatric patients mostly, because it is incompatible to life till adulthood, right? Stomatitis, glossitis, tonsillitis may or may present with the of stomatitis, glossitis, tonsillitis with the dysphagia. And first of all, we always go for the ENT examination to look for the local causes of the dysphagia, right? Esophageal or the pharyngeal web, that is the Plummer-Vinson syndrome or the ring Schatzgering. I will not be discussing, but yes, Plummer-Vinson syndrome I will be discussing, because it is an important, and it is usually asked in the MCQs, right? What are three or four features of these are the various features, except the questions are framed like that for the Plummer-Vinson syndrome. So I will discuss it. As far as the benign or malignant tumor, any tumoral growth, any growth in the esophagus, they are likely to obstruct the lumen, and as a result of which the patient is going to have the dysphagia. Esophageal stricture ulcerations, I will tell you what are the esophageal strictures and ulceration. Like the patient has got the corrosive injury, patient has taken some acid, and as a result of this, you can say mucosal burning, right? The patient has got the esophageal and subsequent healing. First of all, there occurs a mucosal ulceration, and once this mucosa heals, then it is the scarred mucosa, and this scarred mucosa can cause the stricture formation, right? Especially in the corrosive poisoning, we see all of these kinds of patients once we are doing the endoscopy, and I have come across almost all of these things. We have seen the Plummer-Vinson syndrome, Schatzgering. We are seeing a lot in the endoscopy rooms. Esophageal stricture and ulceration, especially post-corrosive injury. We are seeing a lot. Patient is coming with the dysphagia or dinophagia and all these things with the history of the corrosive ingestion. Right. As far as the extrinsic compression is concerned, this is retropharyngeal mass or abscess. The ENT people will be more able to tell about these things. That there is some retropharyngeal mass or abscess which is compressing the esophagus. Right. Enlarged thyroid gland or retrosternal goiter, that is compressing the goiter. Left atrial enlargement in the mitral stenosis, it can cause the dysphagia. Right. Fine. And the aortic aneurysm, any lymph node mass, especially due to the tubercular mediastinal lymph node, that can cause the esophagus, and they all can cause the dysphagia. So just remember, it is huge list as far as the mechanical narrowing is concerned. On the other hand, the motor dysphagia, that is a neuromuscular dysphagia, right? The patient is having the lower motor neuron paralysis of bulbar nuclei, like a 9/10 nuclei, 9/10. Especially if you will come across to see the patients of MND, that is a motor neuron disease. Those who have got the lower motor neuron type of paralysis, there the patient is not able to swallow because the swallowing reflexes are absent, and as a result of which the patient will have the dysphagia. Neuromuscular paralysis, myasthenia gravis. You all must be knowing about this entity. It is an imbalance between the acetylcholine. It is a depletion of the, you can say, acetylcholine, and as a result of which there occurs the you can say weakness. By the end of the day, the patient has got the marked muscle weakness, and this the muscles of the you can say mastication are also not spared, and as a result of which the patient may have the dysphagia. In addition to that, esophageal muscles may also be involved. Right, myopathies, any kind of myopathy can have the esophageal muscle weaknesses, right? And the paralysis of the esophageal sphincter, just remember these names: achalasia cardia, Chagas disease, diabetes mellitus, scleroderma, and all these things. They are there to cause the neuromuscular dysphagia, right? So just remember these things. These are very frequently asked questions in the viva, right? What are the various neuromuscular causes of dysphagia? Anybody of you can tell about the mechanical causes, right? Because they are numerous and easy to interpret, and you will be seeing in daily life. But as far as the motor neuromuscular dysphagia is concerned, yes, these things should be kept in one should keep in their mind once dealing in the case of dysphagia. Yes, if there is no mechanical obstruction, patient is having the symptoms of dysphagia, then you should look for the neuromuscular dysphagia. Diagnosis: a good reliable history. Again and again, medicine is all about the history, right? It is not like surgery. Patient is coming to you with a lump, 2 महीने से बढ़ रहा है lump, अब ये पहले से इस साइज का था, अब इस साइज का हो गया. You just examine the things, it's okay, and you are just taking it out. No, it's not like that. Medicine is all about the history, right? If the patient is having a good reliable history, and yes, if you are certain enough, yes, these are the things which can cause a dysphagia, because there is a very, you can say, narrow line between the absolute dysphagia, between the dysphagia and the globus. Fine. Background risk factors, as I told you, that the patient has got a history of corrosive injury, patient has got the plumber wilson syndrome or something like that, then yes, your diagnosis is much more certain that the patient is having some mechanical dysphagia. If the patient is having some neuromuscular paralysis, patient is labeled with myasthenia gravis and all these things, then you can think of that patient might be having the neuromuscular dysphagia. And rather than doing the endoscopies and all these things, because doing the endoscopy in neuromuscular disease patients can be detrimental, because the patient can aspirate, right? So, and also the clinical characteristics of the dysphagia, right? As I told you, characteristics: dysphagia to solids, mostly it is mechanical dysphagia. Dysphagia to solid and liquids, it is motor dysphagia, right? If there is some mechanical dysphagia, like some tumor is there, some growth is there, and there is usually first the dysphagia will be only to the solids, mind it, right? Because liquids they will be able to pass, but if the obstruction is severe enough, then the dysphagia to liquids will also occur. Dysphagia is solid and in motor dysphagia, the patient will not be able to swallow, right? And as a result of which, the patient will be having the dysphagia to both solids and liquids, right? Fine. Transient dysphagia, right? Inflammatory disease like glossitis, stomatitis, esophagitis. Once you tackle these things by giving multivitamins or treating the underlying cause, then these things likely go. Fungal candidiasis, esophageal candidiasis, or the candidiasis I told you in the last lecture, that it can cause the dysphagia, and it causes oral candidiasis can further progress into the either into the lungs or into the esophagus, and the result of which there occurs the patient may have the dysphagia. Fine. The progressive dysphagia is a esophageal tumors. Again, I am telling you that the progressive dysphagia means that initially the patient is able to take the solids, but later on, as the time passes, as the tumor growth increases, the patient is not able to take it, and even the patient can have the absolute dysphagia, that is the dysphagia to solids as well as the liquids, right? Dysphagia with chest discomfort or heart hiatus hernia, GERD, all these things I will be telling in next slides. That hiatus hernia, gastroesophageal reflux diseases, these are the dysphagia with chest discomfort or heartburn. Associated dysphonia and nasal regurgitation, 9 and 10 cranial palsy. Most of the time, if you will have a patient of bulbar palsy and pseudobulbar palsy, they will have the complaints of this nasal regurgitation of the food. And you all of these things you will learn once the neurology part will be taught to you, right? Weight loss and dysphagia, again suggestive of malignancy, right? We see a lot of patients who are coming to us with a background history of smoking and all these things, having the dysphagia for last 3-4 months. It is progressive dysphagia, and most of these patients, they are usually cachexic. They have lost the significant weight loss. They are markedly emaciated, and once they give the history, then, and on background of this smoking and all these things, almost our diagnosis is certain that yes, we are dealing with some malignancy, and it is probably causing the dysphagia to the patient, right? As far as the just a minute. With dysphagia is concerned, it can be seen in the left recurrent laryngeal nerve palsy seen in patient of mitral stenosis, and what we call the Ortner syndrome. The old examiners are of habit of asking this question, right? But if the patient has got the mitral stenosis, and if he has got the hoarseness of voice, what is that syndrome called? That is the Ortner syndrome, because of the left recurrent laryngeal nerve palsy. Just remember that entity. As far as the investigation dysphagia is concerned, right from top to bottom, we will discuss complete hemogram. Complete hemogram, if the patient is having some malignancy or something like that, right? Patient may have the anemia, right? Patient may have iron deficiency anemia, something like that, because of the decreased oral intake, and as a result of which, the anemia occurs. Anemia, in addition to microcytic or megaloblastic anemia, can occur. Chest X-ray may be of helpful, because if there is some mediastinal widening is there, then it will be seen on the chest X-ray. Otherwise, it is less of utility as far as the any carcinoma or any carcinoma is concerned. But yes, chest X-ray can be of help if there is some any foreign body obstruction is there, like a quant. Coin is totally radio opaque. It will shine like a silver, right? If or some the batteries are there, some fine batteries are there, and especially in a case of children, right? The coin batteries which they put in the toy, which are put in the toys, they usually ingest that, and they can cause a dysphagia. Coins, batteries, and all these things. Chest X-ray. If you do the chest X-ray, and if it is there, if it has got stuck over there, then they will be shining like silver on the chest X-ray. As far as the barium swallow is concerned, if you can remember my second lecture, when we dealt about this GI investigation, and I showed you about the barium swallow of CA esophagus, that uh, if we do the barium studies, then the barium is a radiopaque substance, and it will totally fill the esophagus as a whole tube. But if there is some breach in mucosa, if there is some growth, then this growth will not be filled by the barium, because it is solid growth and it is not hollow one. And as a result of which, there will be the breach in the continuity of the column of the barium, and as a result of which, on again emphasizing on background of history, right? You can make a diagnosis. Yes, the patient might be having some mechanical dysphagia. Upper UGI endoscopy. Endoscopy, it is of utmost important. And as far as dysphagia is concerned, you can see the beauty of this upper GI endoscopy once you visit the endoscopy suite in the C block. Once this COVID era is over, then we will be again starting that room, and that we see a lot of cases. In fact, I must tell you that daily, 4 to 5 endoscopies are there which are pertaining to dysphagia only, and we see all type of patients, be the Plummer-Wilson syndrome, be the Schatz-Giering, esophageal webs, carcinoma, corrosive injury, and all these things. And and dysphagia is usually diagnosed by the UGI endoscopy, especially the mechanical, mostly the mechanical dysphagia, not the neuromuscular dysphagia. And you can come across to see all type of entity in the endoscopy room of ours. As far as esophageal manometry, it is reserved for the diagnosis of ecclesia cardia. I am not going into that detail because it is beyond your scope at this point of time. But just remember that the esophageal manometry is for the ecclesia cardia. 24-hour multi-channel impedance manometry, it is used for the confirmatory diagnosis of the GERD. Again, I am not going into the investigation, right? Just these are the not going into the detail of this 24-hour multi-channel impedance manometry, because it is again beyond your scope, right? Treatment again, as I have been telling in my previous lectures, that treatment is targeted towards addressing the underlying cause of the dysphagia, right? Dysphagia is not per se disease. Dysphagia is a manifestation of some underlying cause, right? If you remove that cause, then the dysphagia is be likely to disappear, right? The treatment target toward the addressing of the underlying disease, like there's some mechanical obstruction due to some battery, some fine, then you remove it from the endoscope. If there is some Plummer-Wilson syndrome, if there is some esophageal web is there, then you can break it through the endoscopes, right? If there is and we are doing all of these things. We are doing the dilatations of these esophageal webs. We are doing the dilatation of the esophageal strictures. Usually we are taking out this foreign bodies which are impacted in the esophagus, and once you do it, patient is totally relieved and he will go home within half an hour, right? And the important one to discuss the Plummer-Wilson syndrome, or the Patterson-Kelly syndrome. These are both are synonymous, and the Patterson-Kelly syndrome is a name which they pronounce in the UK, United Kingdoms, and the Plummer-Wilson usually is a term which is used in the USA, right? So just remember that K is for the UK, that is the United Kingdom, right? Otherwise, it is little bit difficult to remember. Fine. So Patterson Kelly, but both the terms are synonymous. K is for the UK, that is the Patterson Kelly is the term used in the United Kingdom. It is characterized by the iron deficiency anemia, anglostomatitis, glossitis, polynychia, and dysphagia. Right. Again, I'm telling you, very frequently asked MCQ with pertaining to this syndrome. Right. They will give you 3 or 4 options. All of these are present in Patterson-Kelly or Plummer-Wilson syndrome, except, right? So just remember the iron deficiency anemia, anglostomatitis, glossitis, polynychia, all you must know that is a spoon-shaped nails, and the dysphagia. Fine. Due to the iron deficiency anemia, there occurs the degeneration of the mouth, oropharynx, and the esophageal mucosa, and there, because of this degeneration, of the mucosa of the mouth, there occurs the post-cricoid web. Just remember these things. Don't go into that detail how they are going to be formed and this and that. Don't go into the detail. Just remember that there occurs the formation of post-cricoid web, what we call you can say in Hindi jala, right? You must be seeing in your household all the webs, and it is like a web that it is causing obstruction, fine, to the normal esophageal pipe, and as a result of which the patient may have the dysphagia. Mind it is a precancerous state, so needs attention, right? And the treatment is by the correction of iron deficiency anemia and stricture dilatation. We do often do this type of the stricture dilatations in the Plummer-Wilson syndromes, and they have all the features. We have seen the females at least, if I'm not wrong, I have seen at least 10 to 15 patients of this Plummer-Wilson syndrome, and in which some require dilatation, some require uh, and some require other intervention. And if we treat their iron deficiency anemia, they have got the typical. All of them had the typical appearance of iron deficiency anemia. Patients were anemic. Patient was having stomatitis and all these things. Squalenitis, spoon shape. Typical picture were there in those patients who were having, and the patients are presenting with the dysphagia. Especially in females, I have seen this syndrome, and with the help of this web, what we do that with the help of endoscope, we just break this web little bit forcibly, right? And after that, we just dilate this, so that once this web is broken, uh, patient may or may not need the second or third session of the endoscopic intervention, or otherwise they do well. And in the meantime, we correct the iron deficiency anemia, and the patient usually do well as far as the Plummer-Wilson syndrome is concerned. So just remember this entity. Again, another important entity as far as the esophageal disease is concerned is the gastroesophageal reflux disease. It is defined as a reflux of the gastric content to the esophagus, resulting in the inflammation of esophagus. Fine. See, this is the anti-reflux mechanism. This is normal mechanism in me and you and everyone, right? If peristalsis is there, there is a diaphragm, right? And a short parts of the esophagus is below that diaphragm. This is the what we call the intra-abdominal esophagus. There is a little bit. This is the lower esophageal sphincter. There is a normal gastric emptying is occurring, and as a result of which there is, you can say, there is angulation, right? Fine. Intra-abdominal esophagus, angle between the esophagus and stomach, and the normal gastric emptying, as a result of which, if you are taking the food, right? If you are taking the food, and this LS, that is the lower esophageal sphincter, all of these they form the anti-reflux mechanism, because abdomen is a pressure, you can say pressurized chamber, right? If this anti-reflux mechanism will not be there, right, this obliquity of the angle, this lower esophageal sphincter, right, this normal emptying, and the intra-abdominal part of the esophagus, all of the food which you are taking, then it is likely to come out. Because of the increased intra-abdominal pressure, the food will be pushed up, and as a result of which you will vomit all of the food which you have ingested, right? But more so when you are in the lying position, more so when you have taken the food in plenty, right? And as a result of which the patient may have the reflux. What happens in the GERD, that is the gastroesophageal reflux disease, that they occur the impaired or the reduced LES tone. It may occur in a variety of uh, conditions, especially diabetics, obesity, right? There occurs a reduced LES tone, failure to increase the LES tone with increased intra-abdominal pressure. This LES tone is totally lost, especially diabetics, hypothyroids, patients who are obese, right? And this LES is totally in a impaired state of, you can say, closure, and as a result of which all of the food it comes out of it. There occur the impaired esophageal mucosal clearance. Impaired esophageal mucosal clearance may occur in the atresia cardia. I will tell you. There can occur the delay of the gastric. There can occur the delay of the gastric emptying, and here you can see that this obliquity of the angle between the this esophagus and stomach, it is almost lost, right? The intra-abdominal part of the esophagus, it comes out of the it comes through the abdominal hiatus, right? Diaphragmatic hiatus. Fine. So these are the 3 or 4 mechanisms that if the patient has got the hiatus hernia, what we call the hiatus hernia, I will be telling you what is hiatus hernia. The patient has got the hiatus hernia. There is a gastric dilatation or autonomy, especially in diabetics, and you will see, and in your household, in your neighborhood, and all these things. Those patients who are obese, who are having diabetes, who are having, especially those who are smokers, especially, right, alcoholics. In alcoholics and smokers there is always an impaired and reduced aldosterone, and all of these patients, they are likely to have the persistent GERD symptoms. Once they lie down, they always say all the food is coming into the mouth, right? They always say that there is some heartburning is there. They always say that there is some water brash is the, you can say, the regurgitation of the sour fluid into the mouth, because the acidic content is all sour, and once this acidic food, it comes into the mouth, it gives like sour sour, but I meant to say that is a खट्टा, कि most of the time the patients say that जब भी लेटते हैं that खट्टा पानी मुंह में आ जाता है. These are the frequent complaints which we encounter in the OPDs, right? और जैसे ही लेटते हैं रात को, खाने के बाद पेट ऐसा लगता है कि भरा भरा हो गया रहेगा, ऐसा लगता है छाती में दर्द हो रहेगा, और मुंह में खाना आ जाता है. Or again we have to wake up in the night again and again because of these problems. So these are the reflex mechanism, and most of these things are occurring in diabetics, hypertensives, with patients who are alcoholics, smokers, old age, debilitated persons, moribund, bedridden patients. These are the frequent complaints which occurs in these patients. The clinical features: heartburn. Heartburn is a deep-seated retrosternal pain, often mistaken for the cardiac pain. But yes, it is a heartburn is a close mimicker of the typical chest pain. Typical chest pain suggestive of the cardiac etiology, and one must differentiate. One must differentiate heartburn from the typical chest pain, which is related to the cardiac cause. Right? Heartburn, they are usually deep-seated retrosternal chest pain. They may or may, and the classical presentation of the chest pain, which is peculiar to the cardiac, is that they goes into they extend to the jaw. There is severe pain, retrosternal, and all these things. All of these things, they can happen with the symptoms suggestive of the GERD. But most of the time, again emphasizing the role of the history, most of the time the patients say that these pain, they usually occur after meals, especially after meals, that is postprandial states, once they are in a very much fed state, and if they lie down. And they usually, the patients say that somebody in the household, somebody from the neighborhood, right, has given some antacids like some PPI, pantoprazole, or something like that, some diagen syrup, and they got relieved. So by this only we can differentiate that yes, the patient may be having some heartburn, right, and it is not the cardiac origin pain. But this is the close mimicker, I must tell you. Water brash, as I told you, it is a regurgitation of the acidic food and food into the mouth, and there is a heaviness in chest associated with the nausea. Extra GI symptoms, very particular and important to mention, right? Patient may have the exacerbation of the asthma. I am not going into that detail how the exacerbation of the asthma occurs. Patient may have the aspiration pneumonias, right? Especially the old age debilitated person, moribund person, those who are bedridden. Patient may have the aspiration pneumonia because of a regurgitation of food into the mouth, and as a result of which the patient may have the aspiration of this food into the lungs. Patient may have the hoarseness of voice because of all this acidic food, which it comes in contact when it is regurgitated, it comes in contact with the vocal cords, it comes in contact with the epiglottis and all these things, and as a result of which the patient may have the hoarseness of voice. Uncommon symptoms are dysphagia secondary to strictures. If these GERD symptoms, they are not dealt with, then as a result of the ulcerations, as a result of the because the back pressure, because of the food, the acidic food into the esophagus mucosa is not acid resistant as compared to the gastric mucosa. Gastric mucosa is the columnar mucosa, and the esophagus is the stratified squamous epithelium, right? So it is not acid resistant, and as a result of which there occur the ulcerations, and if these ulcerations they heal by their natural course, they can lead on to the strictures. patient may have the, due to the ulcers, patient may have hematemesis. We have seen the patients who come to us with a history of hematemesis, and once we do the endoscopy, then we see that there is a severe esophagitis there, that is a esophageal inflammation is marked in these patients. As far as the diagnosis is concerned, again it is done by the UJ endoscopy. By doing the UJ endoscopy, we are able to see the ulcers and all these things. We are able to see the tone. We are able to see, assess the tone of the lower esophageal sphincter. Right, barium swallow again is of some utility. Right, esophageal manometry, again I am not going into the detail. It also helps. 24-hour channel impedance manometry, it is the most accurate one to diagnose. If somebody asks you, if some MCQ come, that what is the most common, what is the most important diagnostic modality for the diagnosis of GERD, just check this thing: 24-hour channel intraliminal impedance manometry. Right. Complications. As far as the complication of GERD concerned, esophageal ulcerations, strictures, as I told you. Barrett's esophagus. Barrett's esophagus is a term which is used for the, that is the gastric mucosa is being that the esophageal mucosa is being replaced by the gastric mucosa, right? Because of the continuous GERD, right? Columnar epithelium mucosa is being there in the lower end of the esophagus, and it is a precancerous condition, so should be seriously dealt, right? Uh, and in a subset of patient, no, in a very small proportion of patient, these ulcerations, Barrett's esophagus, they can lead on to the carcinoma of esophagus, but it is in very less proportion of the patient, because most of the time the patient, they usually come to us because of these complaints till the carcinoma of the is very late happening, and by that time the patients are usually treated with the PPI and all these things. Treatment: dietary and postural adjustments, right? Again, very important, dietary and postural adjustment as far as the diagnosis of GERD are concerned, right? I'm putting much emphasis on this topic because you are seeing daily these type of patients, right, in your neighborhood, right, at your home, in fact among yourself, among your friends, that the patient are having the symptoms of GERD, right? So dietary and postural adjustments are must, right? I always tell the patients that our medications are a bridge to the are a bridge. The treatment lies with you only, right? Our medications, we are going to give you the treatment for a couple of weeks or couple of months, because the treatment is because the treatment lies with you and not with me. The definitely treatment lies with you and not with me. And first and foremost is the dietary and the postural adjustments, right? But we ask the patient of GERD that they don't have to smoke, they don't have to drink, right? Stop smoking, stop drinking. They don't have to take the too much amount of tea, coffee, and these chocolates, right? Because all these tea, coffee, chocolates, and all these things, what they do, they relaxes the LES, lower esophageal sphincter relaxation, they occur, right? We ask the patient that you take the food in split, right? If you're so A split means that if you're taking the meals for 3 times a day, then you split these meals 4 or 5 times. If you're having if you're taking suppose 4 chapatis per time, then reduce it to 2 or 3, right? Don't lie just after taking the food, right? Because of this decreased LES tone, because of the diaphragmatic push-up, because of the increased abdominal pressure, all of this food is going to come out of the LES, and as a result of which it will cause the heartburn and all these symptoms. So we usually ask that you should not lie down, you should move around for at least half hour to 1 hour after taking the foods. Don't take any junk foods, right? Avoid drinking, smoking, tea, coffee, chocolates, right? Especially the patients who are on who are the calcium channel blockers and all these things. There are some medications are there, uh, which promotes the GERD. So we just take care of the things. Especially the calcium channel blockers are the one which do the mischievous things as far as the GERD is concerned. So and we ask the patient that you should drink a lot of water, so that the food should move downwards from the stomach, right? If the patient has got the diabetics, patient diabetic gastroparesis is well known term. Diabetic patient has got the hypothyroids have got the sluggishness of all the organs, right? Slowness of all the organ movements, right? So we usually ask the patient that you should control your diabetes, thyroid, otherwise these things are not likely to go and you will have to be on treatment for long. And in due course of time, the treatment may not be much beneficial as it was initially, right? Avoidance of the precipitating factor, as I told you, tea, coffee, and all these things. Use of the H2 blocker, H2 receptor blockers, and proton pump inhibitors. You all must be knowing about the H2 receptor blockers and the proton pump inhibitor. But are these entities, that is, the H2 receptor blockers are ranitidine, cimetidine, famotidine, and all these things. The proton pump inhibitors are the pantoprazole, lansoprazole, dexlansoprazole, and all these things. The detail of H2 receptor blocker and proton pump inhibitors I will take in next lectures once I will deal with the gastric ulcer and all these things. Just remember the use of H2 blocker, proton pump inhibitors can be there. Addition of prokinetic drugs, right? Prokinetic like the domperidone, metoclopramide, all are these. They are the domperidone antagonists, right? And as a result of which, they helps in the, you can say, propulsion of the food toward the from the stomach toward the intestine. And these are added if there is no elevation of the reflux symptoms is there, right? So this is just an algorithm if somebody can remember, right? Though it is a little bit difficult for you at this point of time to understand, but this is the typical algorithm: heartburn and a sore rectal or the sore regurgitation, no alarm symptom, lifestyle modification is there. Lifestyle modification is must, no doubt about it, right? And this is the things that are the PPI dose optimization. We usually give the patient PPI to receptor antagonists or the antacids, right? If after this thing S2 receptor blocker of PPI, there is PPI dose dose optimization of the PPI means that is a double dose of the PPI. If there is no relief, then we do the endoscopy. If there is endoscopy, there is a normal endoscopy and all these things. Then we either do the sorry we continue with the PPI. If not relieved, then we can add with the H2 receptor blocker at night for the nocturnal symptoms and all these things. If still not there, then we can add with the prokinetics. And sometimes the patient may require the addition of this tricycling antidepressants or the SSRI, that is the serotonin selective reuptake inhibitors. So this is a difficult one for you to remember, but this is the practice which we follow daily in a patient of the in a patient who are having the GERD symptoms, right? Another term is the hiatus hernia. Hiatus hernia is the hernia, as you all must be knowing. The surgery people must be dealing about it. There is a sac protrusion is there, right? So there the herniation of the part of the stomach into the esophagus. It causes resultant gastric content reflux into the two type. It is of two type: sliding paraesophageal. See, this is the normal. This is the normal physiology. In sliding, what occurs that this LES it comes up, and there occurs the this one, and here it comes there, and this is there. This is sliding hiatus hernia. A part of the esophagus that it comes out, the intra-abdominal part of the esophagus, it comes above the diaphragm, right? The paraesophageal, that a circulation occur in the LES is normal, but the circulation occurs in the esophagus wall, and as a result of which there occurs the paraesophageal hiatus hernia. These are usually dealt in the surgery. Again, the diagnosis is by the UJ endoscopy. We find a lot of patients with the hiatus hernia, and there are certain parameters in the UJ endoscopy by which we can diagnose that the patient may be having the hiatus hernia. Barium swallow, yes, can be of help. CT scan of the thorax and upper abdomen is of help in diagnosis. Treatment, again, the lifestyle modification, as I told you. Third, right, long-term use of PPI. Patient may require the long-term use of proton pump inhibitors because they inhibit the gastric reflux, right? In non-responders, if the patient doesn't respond to these things, then the patient may require the surgery in the form of fundoplication. Again, this all will be dealt in the by my surgical colleagues. That what is the fundoplication? Just remember, there is a nasal fundoplication or tupet fundoplication. They may be offered. Coming to another entity of the esophagus, that is the carcinoma of esophagus. Just remember, mostly two types: squamous cell carcinoma, adenocarcinoma. Squamous cell carcinoma mostly in smokers, up to 2/3 of the esophagus involved. As far as the adenocarcinoma is there, it is below 1/3. Risk factors: smokers, alcoholics, Plummer-Vinson syndrome, atresia cardia, celiac disease, right, and the Barrett's esophagus. Just remember all these things, right? Clinical features: progressive dysphagia, initiate for solids and then for liquids. Metamesis: patient may have the hoarseness of voice because of the recurrent laryngeal nerve involvement. Patient may have the dyspnea because of the compression of the trachea. Investigations again by the UJ endoscopy, barium swallow, CT scan of thorax and upper abdomen. Treatment: all this will be dealt by surgery people. So I'm just giving an overview that patient may require surgical dissection, patient may require the chemoradiotherapy, and if there is luminal obstruction is there, then we usually do the stenting, right? We are doing it here, the esophageal growth stenting, that we put a metal stent in the esophagus to relieve the obstruction, and the stent remains in situ for the remaining life, right? Another entity, just if one or two slides about this entity. Just remember this thing, that it is achalasia cardia. It is a motor disorder of the esophagus, and it is characterized by the progressive dilatation of the lower esophagus. It is secondary to the hypertonic LES, which fail to relax in response to swallowing. Just remember this thing, no one is going to ask you. Just remember from the MCQ part of view that achalasia cardia. Etiology is largely unknown, and the speculative theory includes the ganglion cell degeneration, failure of non-adrenergic, non-cholinergic innervation, and the lower esophagus, right? Clinical features include the intermittent dysphagia, more for the liquids than solids. Yes, this is important to mention. If there is mechanical dysphagia, if there is some obstruction, then the dysphagia will be more for the solids than liquids. But here in the achalasia cardia, in which the LES fails to relax, and as a result of which there occurs dilatation of the esophagus, the patient will be having the more dysphagia for the liquids than the solids, because solids as a bolus, and as per the gravity, it goes through the this hypertonic LES, but liquids will not be able to pass. There is a sensation of stickiness of food in the esophagus. Patient may have the halitosis because all of the time the patients will be having the food in the esophagus, and it becomes a mess for us to do the endoscopy of these patients, because once we insert the endoscopes in these patients, all of the food, which is very foul smelling, and they vomit it out, because all of the food is being at stasis in the esophagus. Recurrent, especially of the vomiting, especially postprandial, and the severe form, they may present with the pneumonia. A diagnosis by the barium swallow, UJ endoscopy, and the esophageal manometry. Esophageal manometry is the investigation of choice for the diagnosis of this achalasia cardia. Upper GI endoscopy may be of help. Barium swallow may give you a clinch, but the esophageal manometry is the gold standard for the diagnosis. Treatment: just remember, balloon dilatation, injection of the botulinum toxin at the lower esophageal sphincter, surgery, Heller's myotomy, and the new entity, if somebody can remember, that is a poem, that is a peroral esophageal myotomy, right? And what we do, that through the endoscopes, we make a tunnel into the submucosa, and we just cut the you can say the muscles, so that the hypertonicity of the LES goes. But yes, the surgery people will be telling about the Heller's myotomy, and balloon dilatation are not being done nowadays, and this is this the gastroenterologists are now doing a lot as far as the achalasia cardia is concerned, right? So this was about the disease of the esophagus. Just remember these things, that these are these things you are likely to see, you are going to see in daily life, right? And if I'm not wrong, that if we see, suppose 500 600 patients in medicine, then approximately 40 to 50% of the patient, they come with only symptoms related to the only symptoms related to the GERD or the acid peptic disease, that is related to the stomach, which I will be dealing in the next class. So here you can estimate that these patients, they are uh, they they are the main chunk of the medicine OPD rather. In fact, the gastroenterology practices also per se in the medicine OPD, that 40 to 50% of the patient, they come just for these ailments, that is the GERD or the APD. So now you can recognize the uh, you can estimate the importance of these topics, and these are not very difficult to treat, right? You just have to convince the patient, you just have to reassure the patient, you just have to treat the patient with the medicines, right? uh, in a selective and protocolized manner. Fine. So from next time, I will be starting with the disease of the stomach, right? If there is some queries or some question, then you can mail it to me, and I will be happy to answer these questions. Thank you. Thanks a lot for the patient listening. Right. Kindly mark your attendance and leave the class, please. नहीं मैंने बोला आप कर देना